Welcome to season 3 of Love Infection Prevention podcast. With me, Michelle Strange. This season, we're diving deeper into the nuances of infection prevention and patient safety in the dental setting. And so each one of these episodes, we're going to be tackling specific topics with incredible guests to bring you practical insights and hopefully valuable strategies to elevate your infection control practices. So today we're going to be discussing disinfection and barriers and environmental infection control with my guest, Alyssa Aberle. How are you?
I'm good. How are you?
Very good. Alyssa and I go way back in the infection control space. We're very nerdy about this topic, so I'm excited to chat with you.
Yeah, whenever we find something on social media or have an experience, we're always like right to the group text right away. So
Absolutely. Absolutely. And it's nice to have like sounding boards for things. I think we've chatted about disinfection and barrier wraps and kind of got a consensus. And I think that's really nice because even though infection prevention is mildly black and white, there's a lot of gray. There's a lot of gray because the guidance isn't always super clear, and all of our operatories and our dental settings are very unique. And I think that it's sometimes hard to take that like mobile dentistry, like taking a dental recommendation for a permanent brick and mortar setting and putting it towards mobile, like that always gets so complicated. So if we dive into the topic of disinfection, barrier wraps, really thinking about our environmental infection control, you are working with a lot of people with your, I'm curious, do you have some very specific things that you say often to them? Like you're just repeat, like if I could just play, just say this.
wow, like here's my recording of myself. I mean, absolutely. I think barriers and disinfection is a confusion for a lot of people. And yeah, so I mean, I think disinfection and barriers is a confusion for a lot of people who work in dentistry. And I see a lot of questions about these on social media too, where people are like, I'm working in an office and they're doing it this way, but I learned this way. Or I learned that we had to wipe spray and leave it for 10 minutes, but now somebody's telling me I only have to do it for a minute, but why? And, it's just kind of that lack of deeper understanding of why we're doing what we're doing. Because I think once you understand why, then it kind of clicks and makes sense usually. But if you don't know why and you're just going through the motions, there's a lot of confusion. So I think a lot of times when I'm working with offices, I'm like, okay, let's take a step back and just talk about what are you doing? Like, show me what you're currently doing. And then along the way, I'm like, why do you do that? How long do you do that? Why are you doing that? And if they don't really understand those steps, then I'm like, okay, we got to take a pause and like talk through it, because clearly you're just doing it because somebody told you to, not because that's the right way or because the instructions for you said so, or whatever the case may be. So a lot of the things that I see is when we start going through those steps, one of the biggest things that kind of is a pet peeve of mine is when people use like the wrong word. And I know sometimes that's like a semantics thing, but they'll be like, okay, so when I'm doing operatory turnaround, I come in here and I sterilize the dental chair. And I'm like, okay, stop. Like, did you sterilize the dental chair? Did you like put it in the autoclave? And they're like, no, but you know what I mean. And I'm like, do I know what you mean? Because if you don't know what you mean, then it's hard for you to tell somebody else what you mean. I know it seems like semantics, but it's really important that we communicate using some of the right terminology. So a lot of that is just like really understanding the root of what we're doing. I will often come into a room, like into an operatory, and a handpiece is still on the hose, or the Cavitron handle is still on the Cavitron, but like nobody's been using that room sometimes like at all that day. And so then I'm like, well, why is that still there? And they're like, oh, well, we didn't use that on the last patient or something. And so we talked a lot about that. Like if I come in the room and there's still stuff there that should have been removed to go get sterilized, those are some of the like early red flags that I'm like, we got to talk about this process a little more so that we really understand what's happening. So a lot of it is just kind of taking that time to talk through it and think through it And then once you do, usually people start to get it because they start to understand that why.
I think you brought up something that is very important at the top of this answer, and that was, I learned it this way. And like how often that happens. And I think you and I, as clinicians, that we are still practicing, we're in it. I always like to tell people, like, I am you. I swear, like, I am trying to find the ways to hustle, survive the day, and stay in compliance. Like, and it's not always easy. But I think if we look at our practices right now, and I'm in it 19 years as a hygienist, 25 in dentistry, and I'm still doing it thinking it's a 10-minute kill time when we know there's constantly innovations. There's new products and new wipes and new sprays and disinfectants on the market. And it doesn't cause us to go, well, is there something that I could be doing that's different? Or should I still be doing this? Or is this the right way? I and we call that legacy errors. We talk about that a lot. I think that's the first thing, like the first self-audit. Like, I'm still doing it the way that I learned 19 years ago.
Absolutely. Yeah, there's so many things that when I work with offices, some of the offices I'm working with, they're just doing annual like retraining, but some of them have been in trouble with the dental board or have been inspected by the dental board. And so I'm coming in after the fact. And so when I'm talking about stuff, I'm like, if your answer is because Susan told me that that's how we do it in this office, then that's a hard stop. And if your answer is like, well, that's the way we've always done it, that's also a hard stop on a lot of things, not just infection control. So I'm always like, you play the game of telephone. We talk about this a lot with the actual instructions for use. But then like this person taught person number 2 who came to work in the office, and then that person trained the next person, that person trained the next person, that person trained the next person. By the time we get to person number 7, the instructions have changed completely. And so now it's like, where do we start? And is this even what we're supposed to be doing? And you and I have talked a lot about that's why you need standard operating procedures. And that's why you need to understand the instructions for use. And that's why you need to, know all of the actual instructions and have some kind of baseline to go back to. Otherwise, we get lost in that translation for sure.
That's so true. I am curious because one of the things that I'm always working on myself for, and then one of the things that I see more often when I work with other clinicians is how often and how easy it is to cross-contaminate when you are doing that operatory turnover. Are there any suggestions that you are often making with people to prevent that cross-contamination, be more aware of it?
I mean, it's so hard. I always recommend that offices as a team watch the "Is Saliva Were Red" video. And I know it's like something I'll watch in school, but again, we have to remember that not everybody on our team is a hygienist or a dentist and maybe watched this in school. And if they did, it could have been 20 years ago. And there's a newer version of that video out, which is awesome. But it's like, it really puts you in that mindset of, like, when we see blood on stuff, that's gross. But there's saliva on everything, and we just don't think about it. And so if you thought about if your patient sat up at the end of the procedure and could see every spot you touched in the operatory, would they feel comfortable, or would that be a huge red flag for them, So I think really just kind of, again, taking that step back to think about the process is really helpful. And I think it's really important to do it as a whole team, because oftentimes there's a couple of champions in each office and then a few that are less invested in it. And so you can't just have one person caring about cross-contamination, because sometimes you'll have people hopping back and forth between rooms, or you're sharing rooms, or you're sharing spaces, or stuff is coming in from another room. And so you really want to make sure everybody gets the same thing and is on the same page. And that's what I talk a lot about with barriers, because if you're doing 100% barrier wraps on everything and the person in the operatory next to you is doing 60%, well, what happens is someday somebody's going to help somebody flip over a room, and you're going to assume that everything was covered in a barrier, and how you're going to handle that is much different. And then you're going to find out later that only 60% of it was covered in barriers. And so now there's a lot of surfaces that were untouched and are very dirty. So it's really important that everybody kind of gets on the same page and that you have that standardization. Plus, I think for a patient perspective, they come in and they see well, that person had plastic on everything and this person doesn't have it on anything, or like this person got
Oh,
the
yeah.
PPE on, this person doesn't. It starts to like, they see that contrast and they start to ask questions too.
So you brought up 2 points that I'd love to kinda dive deeper in. One is the continuity that is needed, and I do believe a lot of people are like, "This is the room I'm always in," or like, "This is the room there," like, I don't do these things, but there's always a moment, right? Like, you might go help or you're running behind. I'd love to touch on that a little more, and then also, like, the fact that patients are watching. And I think that it's getting we see that more and more. I, in fact, had a patient the other day that was put on my schedule specifically because they knew they had brought up infection control stuff prior, and they're like, "We'll put her on Michelle's schedule," because, like, obviously, I'm gonna be obnoxious about all of it,
Right.
and so I was like, "That's so interesting," like, we know this about this patient, but, like, how many of them are not coming back with feedback saying like, "Well, I've noticed this. So wait, you touched her hair, you gotta wash your hands again?"
And also you're like,
And that was what
that you trust me and that you put that person on my schedule and we can probably figure it out.
but why not everyone?
Yeah, but why can't they see the other person? Because that person should be doing the same thing. So you're like, great, but also,
Right? Like, maybe we have to go back to the foundation
yeah. And there
of our team and, like, are we doing all the things?
there's definitely more awareness today about infection control. And I mean, part of it is the pandemic for sure. Part of it is just social media. And like
Mhm.
heard the phrase recently that we're in like the omniscient generation. Like we have all this information at our fingertips all the time. And so people are seeing videos on TikTok and they're seeing videos and they're starting to notice the differences or hear something that they want to ask questions about. And so they are aware. When I was doing one of our Kim Laudenslager and I, we teach ocean infection control, and we were doing a training at a hotel. And this guy comes over, he's in a meeting down the hall at a different meeting room for like state employees. And he comes over, he's like, "Oh, dental, huh? You're talking about infection control?" And he starts talking to us. And he's like, "Last time I went to the dentist, I noticed that they put on their gloves first and then put on their glasses and their mask and then touched some stuff in the drawer and then did all this other stuff."
That's
And so
crazy.
he's like, as a patient, processing that of like, I don't think that was right. And he's like, "I'm not sure why, but I just know that I don't think that's right." And so definitely people who are non-dental are noticing more.
And for me, if I were to see that as a patient sitting in maybe another medical chair, my thought is if you can't do something as simple as donning and doffing your PPE correctly, what else are you missing in the infection control process? Where are the other breaches happening that I physically can't see? Is it the cleaning step? Is it the drying step? Is it the pouches step? What is it? And that gives me angst.
Yeah, it's like when you go to a restaurant, like I can't see background, I can,
Yes.
but I can see your bathrooms. I can see underneath the table I'm sitting at. I can see how well the table itself was cleaned. And then you can start to make assumptions of other things that maybe aren't happening. And so, same thing with the dental practice. There was an office that had a complaint filed against them. And it was about the dental procedure. Like the complaint was about, the root canal or the crown or the something. And at the very bottom of the complaint, it said, "And I noticed they had Lysol wipes on the countertop, and I don't think those are approved for healthcare." But like that one sentence was kind of like, I don't really know, but that just kind of stood out to me and raised a red flag.
Feel right.
And so it like is just one more layer. I always talk to patients about, or to officers about, if a patient comes in and there's instruments already laid out on a tray, they don't know if those are clean or dirty. And so they can make assumptions, which may or may not be correct. Or if you come into a room and you've already got your gloves on, people make assumptions that those are probably dirty gloves, but they don't really know. But it's just those insights. And I think when we're talking about operatory turnaround and barriers, those are pretty easy things sometimes for people to notice. Like, are there barriers blast off? Are my instruments still wrapped? Did they touch a bunch of surfaces while they were treating me? Like, did they drop something on the floor and just pick it up? Those are the things the patients do see because they're in the room. They don't see your like spray wipe, spray, nada, yada, but they're seeing what's happening during that procedure. And it does maybe show them that some other stuff is not happening.
That's so true. So when we talk about I want to call back to continuity amongst our rooms, especially when we're doing barrier wraps. But before we dive into that barrier wrap section that I would love to have with you, or conversation I'd love to have, can we just review what the protocols are these days for spray wipe spray? Is it wipe discard wipe? Is it one step? Is it two step? Because I mean, I personally even get a little confused when I read it's a one-step process, and then I go and read it, and it's like one step on a clean surface. I'm like, well, ain't that two steps? No.
Yep. Yeah. So it really, first of all, depends on whether you're supposed to clean the surface, disinfect the surface, or some items need to be sterilized. So I always like say, like, let's start there. Because again, if you understand what those different terms mean, then it kind of makes it easier to understand. And then understanding when we're talking about disinfection, which is what we're usually talking about when we're talking about operatory turnaround, because they're clinical contact surfaces, but they're not things, we're wiping down the chair and the air water syringe and the overhead light handle and things like that. Most instructions for use, like you said, will say to clean the surface and then to get it wet again, and then it has to stay wet for that full TB kill time, tuberculosis kill time. And so there are some products now that are advertised as one-step products, and they say, you can just wipe it if it's a clean surface. And you're like, okay, so that, like you said, is two steps. So you did that first wipe, which is the cleaning step, and then the second step, which is the disinfecting step. It still has to stay wet for the full TB kill time in order to be considered disinfected in a healthcare setting. And so if that wipe says that it's a 5-minute TB kill time, most wipes don't have enough liquid on them to stay wet for 5 minutes or even a minute, really. So if it has to stay wet for that full time and you're only using wipe, you're never spraying anything, chances are it's not staying wet for that full time. And so that's what's really important for people to understand, because it's like, yes, you're using a disinfectant. The product is labeled as a disinfectant, but if it's not getting cleaned, then getting wet again and staying wet for that full kill time, it didn't actually get disinfected. And so I'm like, again, it seems like words and semantics, but it's not. It's important to understand like what you're trying to accomplish and what you are accomplishing.
Mm-hmm.
And that's where, for me, barriers come into play, because if the surface has a plastic barrier on it, it doesn't have to get disinfected between every patient. You do just have to, CDC says like you have to make sure it doesn't look like it got soiled and then put a clean barrier on it. And I'm always like, I can't see things. This is the whole point, right? It's still or red. So I always say at least you do that cleaning step and then put your new clean barrier on it. So for me, I'm like, if you had a barrier on it, you don't have to worry about how long that wipe is staying wet for and how much of the surface actually got wet, and standing there and watching and making sure that it stayed wet for the 1 minute, 3 minutes, 5 minutes, whatever. It's so much easier, more efficient to cover those surfaces with barriers, so you don't have to do that whole process between every patient. And so, yeah, it's kind of a trade-off. It's like if you don't use barriers, that in between patients disinfecting is very technique sensitive and sometimes very time, cost. If you use barriers, yes, there is more material costs for barriers themselves, but in the scheme of things, it's going to save you time and money and potentially save you that risk of cross-contamination.
And so this is actually where I think the conversations in infection control get very interesting, and the nuances that I did want to talk about, because I do it just slightly different when it comes to barriers. So I kind of always consider, when you look at the funnel that is environmental infection control, and then we got like housekeeping surfaces, clinical surfaces, and then we take it down a little bit more, and then we go all the way down to like transfer surfaces, touch surfaces, spatter sprays, aerosol surfaces, right? And so when I am thinking about my barriers, I think one nuance is conversation is that not all barriers are created the same, and they do need to be like an FDA cleared barrier. I think like using trash bags and things like that, like that material is getting thinner and thinner. So the potential that it tears, potential that it has a little micro pore in it that could cause that cross contamination is way higher versus like the ones that are a lot thicker and are meant for healthcare settings. And, like I know, for instance, like Kerr has a brand out there and they have a lot of clearance on theirs that it's a thicker material. It's made in a manufacturing facility that's clean, all those different things, right? So then I consider my touch surfaces and my transfer surfaces when I'm removing barriers and wiping things down. So like if I'm thinking about my docking station for that air water syringe as like my transfer, like I cover that whole thing because it is just so difficult to get down into all those different things, right? And so I don't often wipe that down unless I know when I pulled it off, like I contaminated it. But my touch surface, that is my air water syringe, even though it does have a barrier wrap on it, I do wipe that down because the potential for me to shift that barrier or a spatter to come back on that is a lot higher. What do you think about that?
Yeah, no, I totally agree with that. And I think the important thing there is when you are wiping that surface down after you took the barrier off, that's just a cleaning step. Like, and so when people are like, well, yeah, well, we disinfect everything between every patient, whether it had a barrier or not. I'm like, that's fine. But are you actually?
Yeah, that's totally fine.
Usually you think you're doing that and you're not. And so again, it's that understanding of the base level. But I agree with you for sure that folder needs a barrier. That's another thing I see in a lot of offices is they'll put them on the touch surfaces, but not the transfer surfaces. And I'm like, yeah, I'm like, even in hygiene, I mean, I've had a lot of patients, a lot of procedures where that air water syringe barrier is covered in blood, like bloody hand afterwards. And so I'm like, yeah, that's great that that's covered in a barrier. But once you put it in that folder,
Put it up.
it's all over that too, and there are some pathogens that can live in dried blood on a surface for 7, 10, 14 days. So you're like, you don't realize how much you're potentially contaminating and causing that infection spread if you're not covering that holder. And honestly, I get this a lot from dental assistants too, because they're like, well, the dentist that I work with just hates a barrier on his handpiece because it's slippery and it's really hard to hold on to. And so I hear this a lot. And I'm like, well, win-win. If that handpiece is coming off to be sterilized between patients, the handpiece itself does not need a barrier. Maybe the hose, depending on how your setup is, if you're, dragging the or pulling it and touching it with your gloves,
Sure.
maybe. But I'm like, again, thinking of, well, if I'm taking that off and sterilizing it, then no, it doesn't also need a barrier. You can if it makes you feel better, like, or if it's just part of your routine, fine. Well, like, again, it's just thinking through that. But the folder thing is, I'm like, that's a non-argument. Like, that's
Non-negotiable, right?
like getting a barrier.
You absolutely. Yeah. And that actually brings up
That handpiece is getting realized, but that thing.
exactly. And I think the same goes for our suction valves and the on-off. Like, how often, because this is where I think the conversation comes is to the nooks and the crannies. Where are you not going to spend the time? Like, no one's spending, like, you're flipping it up, you're getting into like, no one's doing.
Right.
And so when we barrier wrap it, it's like that Swiss cheese model, right? Like how many like ways or barriers can we create in this situation so that we know that that bioburden is not going into those nooks and crannies so we've cleaned it. It's a clean surface. We barrier wrapped it. We've reduced that risk of it getting into the nooks and crannies. Maybe it got on to like the nose piece or something of our air water syringe, but we're going to take that off and we're going to wipe that down so that gets clean and disinfected. So like we have reduced that risk of transmission with each step in this, because no one is doing, like, no one's getting, like, am I getting it?
I love it. Like, oh no, I do a great job of that. I'm like, okay. And actually, when I bought, Kim and I actually have some of that glow germ stuff.
Yeah.
And I'm like, I would love to do an experiment with an office and like go in and see what all has been touched, because we used to do it at one of the FQHCs that I worked at. They would do it for hand hygiene. So they would have you blow germ stuff on, and then they'd have you go wash your hands, and then you'd have to show them under a black light, like where you missed. And it was like so interesting. But I would love to do that as an experiment with cross contamination, because it would be hard to do, because you're like, it would have to be on a fake patient, you'd have to, and then they look, right. We know that they're kind of being watched, and there's some tricky parts, but you think that you're doing a great job of that. But there's always, especially with those, switches, buttons, things that have nooks and crannies. My favorite one, and I know you and I have talked about this, is when people tell me that they don't need a barrier on their keyboard because they're like, oh, yeah. And they're like, well, I never felt it during an appointment. And I'm like, okay, right.
But also spatter, spray, that is going, that we all know better too.
Even if your computer falls asleep and you just nudge it to wake it up, like now you've touched it. And I'm like, have you ever sprayed the keyboard with the air, like the compressed air? There's so much gross stuff in there. I'm like, don't add disgusting airborne pathogens in there. Like, that's a whole other game. So.
And they're a company called Man and Machine. It's a keyboard-based company that I love to use. And they actually have some swabs from keyboards throughout the country, hospital settings, dental settings, and it is disgusting.
Yeah.
Like truly disgusting.
Yeah, there's stuff. I want technology coming out with keyboards and mice and all that stuff that helps, but those are some of the services that I'm like, why are you not? Why?
Yeah, those are the easy ones, I think. Yes, we cover up. Those are like the no-brainers to me. So it is a little surprising. I would love to, as like we kind of finish up here, and when we talk about that continuity of like, what are we barrier wrapping, and that team approach to this, I'd love to throw out a scenario that actually just happened to me and get your like take on it too. Let's say we're barrier wrapping most things, including the overhead light. I noticed, I don't use the overhead light because I have a loop set of light, but the doctor was using the light. And I noticed when he would grab the barrier on it, that it was just like an overreach, because these barriers on those lights, they don't fit perfectly. They side, they move around. And he was like almost grabbing the T part of it. And so I was like, think that we should just not barrier wrap this and we'll wipe it down. Like it doesn't have that many nooks and crannies on it that if we're going to have to clean and disinfect it anyway, because this is happening, let's just not barrier wrap it. And it really kind of threw a lot of people off with it. And I was like, let's talk about what items in an operatory almost without a doubt should be. I think we've already covered some of them, like keyboards, your air water syringes, your docking station. But what are some that are like, just come to a consensus and then everybody does it? What are your thoughts on that?
Yeah, so the overhead light handle is so tricky. The other thing I've noticed with the overhead light handle is, like you said, you don't use it, but somebody else does. And so sometimes I'll notice those barriers don't get taken off because people use them because they're like, well, I didn't use it. And you're like, but the other person who came in here did use it.
Did they?
Or, like there's that potential because there's not that communication of like, where are we removing. The other one like that is the X-ray button. If it's outside the room, it's got a barrier on it, but people forget to take it off because it's not in the doing their breakdown. But anyway, that's a side note. But I definitely think that overhead light handle is one of those that kind of like, you could go either way as long as everybody is on the same page. And like you said, actually, I think in the new If Saliva Were Red video, I took a screenshot of that exact thing where there's a barrier on that light handle, but the thumb
and they got to
like right next to where the barrier was. So it got missed.
Yeah.
And so, there's definitely that potential to have that false sense of security with some of those things if the barrier doesn't sit well. So that overhead light handle, I agree. I mean, it's not something that's going in the patient's mouth. It's generally smooth, depending on what kind of light you have. You could probably go either way. I am always like, let's try to find something that does like work and or try to teach ourselves to grab it in a different way too, so that you're not overreaching. Because even if you were overreaching, you could start getting into some areas that wouldn't be as easy to clean, and so you have to be careful.
Mm-hmm.
The other one that is like that for me is if you have like that moving countertop, usually like at the head of the assistant that goes from like the doctor side to the assistant side. And a lot of times if people touch it, they'll touch it with a gloved hand. Underside now got contaminated and it might not be getting cleaned or disinfected. So,
Yeah.
like those are kind of ones where I'm like, I see it could go either way. But if everybody's not thinking through it and being careful about how they do it, to me, I'm always like, I just know myself and I'd rather put a barrier on it. So definitely like I default to that. Granted, I work mobile now, so I don't have as many surfaces in my immediate area to cover, but definitely when you're in an office. I think for the standardization piece, like you said, it's kind of let's have a conversation about this. Should we have a barrier on this? Should we not? What I always recommend is as a team set up an operatory, if you have different setups for your like rooms, do it in each room, take a picture of it. Sometimes make a list of what you need. So for operatories 1, 2, and 3, we need 4 of the chair cover size and 3 of the air water syringe size and 2 of this one and 1 of this one. And you can include like your other disposable items there too. And then what Kim and I always talk about with people is to like pre-pack. We call them burritos. It's of like pre-rolling silverware at a restaurant, which I did in high school for my friend's dad's restaurant. But like you pre-roll your packs and you've got 4 of these, 6 of these, whatever. And then when you come to turn over your room, it's easy to just grab one. You don't have to think about what all has to be covered. And then if you end up with extras, you're like, okay, well, I missed something. So it's kind of a good extra check for you and your team too. So I think though, really ideally, it's something you talk about as a team, like in a staff meeting. It's like, go set up a room, take a picture of it. This is what it should look like. And then you can kind of help each other like process through some of those surfaces that are borderline or could go either way.
Oh, that's perfect. I think the idea of setting it up, just practicing it as a team, what makes sense for everybody, and then have those things like the burrito. I do the tray setup. Like, I think it's the same thing. It makes so much sense. Any final words as we close out?
No, I mean, I just think it's one of those things that we do all day, every day with barriers and operatory turnaround. And so again, like I said a billion times, I think just understanding why you're doing it and really going back to the basics. And don't think people are patronizing you when you're talking about it as a team, because it is something that we all, have learned a different way, or we're all in a hurry and we're trying to find an easier way to do it. And so like take all that judgment out of it and just be like, we're doing this because it is the right thing to do. And it is the best way to care for our patients. It's the way to provide them the safest experience. So let's take all the other stuff out of it and just figure out how to do this in the best way that we can do it.
That's perfect. And if anybody wants to chat with you, learn more from you, take a course from you, where do they get in touch with you?
Yeah, so on socials, I'm at Alyssa RDH, ALYSSA RDH. And my company that I work with Kim Louden-Slager, is Louden-Slager Seminars. I know that's a long name to do.
I'll put it in the show night.
No, I'll put it in the show notes. And we do teach ocean infection control and work with offices around the country as well. So we're happy to chat through some stuff or be a sounding board and work through some stuff. And we kind of bounce ideas off with Michelle a lot too. So it's good to have the community of the family for sure.
It is. And I appreciate you coming on for my season 3. And please reach out to Alyssa if y'all have any questions. Definitely follow her. Take any of her courses if you see her presenting anywhere. And I just thank you for your time today. Thank you for listening to Season 3 of the Level Up Infection Prevention Podcast. Don't forget to follow or connect with the guests. And while you're at it, follow me on Instagram, Level Up Infection Prevention. And check out levelupip.com for more details on all the digital courses and the Infection Control Coordinator's Guidebook.